ischemic stroke, what's the role of the cardiologist? Now, as interventional cardiologists, we have vast experience in coronary interventions, peripheral interventions, and renals, and so on. And most of you must be familiar and you must be doing a good work in carotid stent and also with these, the good numbers. But when it comes to interventions in acute ischemic stroke, probably one should have a good understanding of the anatomy of the cerebral circulation and the hemodynamics of it, which are slightly different from cardiac interventions. And of course, a specialized hardware. Now, we know stroke is the number one cause of disability worldwide. And in the 1970s, probably some of you are there, those days when a person comes with a stroke, then we used to do an LP. And if it is hemorrhaging, then we used to land it as hemorrhagic stroke. And if it is clear fluid, then we used to say ischemic stroke and give only Lomodics. Not even aspirin was available or recommended for strokes in those days. So practically no treatment used to be offered to the patient in those days with stroke, and this used to be the consequence of it. This classical image is great. And thanks to the advances in the management of stroke, this scenario is a reality now. Unlike myocardial infarction, we know stroke really takes away the pride of the person. You have to imagine, somebody gets heart attack, still he leads almost a normal life externally. But somebody gets a stroke with the gaits like that, or sometimes bedridden states, it really takes away the pride of the person. It makes him depressed. Not only the patient, but a long-standing burden to the society and also to the family. We see a lot of families, a bedridden stroke patient, probably most of these family members also become sick because they have to do so much of service to the patient. Now, this of course everybody knows, be fast is the slogan. So this is for early recognition of the stroke. This is given even for laymen. They should be able to understand the early signs of stroke and get into the hospital because time is money. The reason is in stroke roughly 2 million neurons die every minute. You have to see the magnitude. And the goal is to restore the tissue perfusion as early as possible so that we can salvage a large number of neurons. Most important thing in the management of stroke is to determine at the earliest if the patient is a candidate for thrombolytic therapy and or endovascular therapy. You can give thrombolytic therapy, still take him for mechanical thrombectomy also, provided it fits into the recommendations. We all know that intravenous thrombolytic therapy has become a gold standard if the person comes in less than 4.5 hours. This is a gold standard, not debatable. But the only problem is, of all the stroke patients, only 3% of the stroke patients are eligible for intravenous thrombolytic therapy, even with a lot of awareness about the stroke. So because it's a negative symptom. If it's myocardial infarction, he gets up from sleep and he gets pain, he runs to the hospital. But if he gets a weakness in the upper limb or lower limb, as a negative symptom, he won't pay much attention. Always they think that we can see tomorrow. That's why the time is lost. Only 3% of the strokes, they are eligible for thrombolytic therapy. And also, intravenous thrombolytic therapy is not very effective for large vessel occlusions. We say large vessel if it's visceral or vertebral or middle circulatory or retinal carotid, not the lacunar strokes. But so this is not effective for large vessel occlusions. Now, if you see the recanalization rates of intravenous thrombolytic therapy, only 1/3 hardly get recanalized. But if you see interventions, there's a 100% recanalization rates, provided you use the correct software and expertise. So this is the journey in the interventions in the cerebral strokes, starting with 1999, the PROACT study which showed intra-arterial thrombolysis to the present generation stent retrievers and tunnel resistors. Now, ideally, a stroke patient, like in coronary care units, he should be treated in stroke care units. where it comprises a stroke neurologist. In neurologists also there are stroke specialists because they work more with the stroke patients. They understand the disease better. So ideally a stroke specialist should be there and interventionist should be there and the rest of the paraphernalia like stroke expert nurses and physiotherapists and so on. This is our stroke team. And what are the intervention strategies which are available? One is clot lysis, we know, and this is clot retrievers with Mercy, Penumbra, and stent retrievers. And of course, as in coronaries, we do stenting or angioplastics. Now, who are the people who can perform this? As of today, a person, a cardiologist, of course, is well versed in the intervention techniques, is eligible to do interventions in strokes, and interventional neurologists and interventional radiologists. But let me tell you, I think who else can be a better person to tackle these interventions, be it in coronaries or cerebrals? I think cardiologists will have a better techniques and skills to perform these procedures. So that's the reason why I present this topic, because some of you cardiologists, stroke is such a common disease that if you get something hardware and some expertise, probably you'll be able to save this devastating disease. It is not life or death. It is the depressing disease. This person is bedridden for years together. You have to imagine. That is worse than myocardial infarction, cardiologist. Unlike stroke interventions in like acute myocardial infarction, ischemic stroke interventions, one should remember that it has a unique set of complications which we don't see in coronary interventions. That is hemorrhages, massive cerebral edemas, and hyperperfusion. This is because of disruption of the blood-brain barrier. So any of these complications can lead to a catastrophic consequences. Here I would like to say one thing. In acute myocardial infarction, if you get a TB grade 3 flow and a good cosmetic result, usually the prognosis is good. But in acute ischemic strokes, it's not like that always. We have seen, we got our fingers. You get a very good flow, very good result. The vessel looks normal, but the patient is sinking, So it is not equal. That's what I always say. Myocardial infarction and stroke, both are not same as somebody says. They're not just the same. There's a lot of difference. That's the reason why we require a team there. Now, it's because the selection of the case. Here also is the difference. If you say myocardial infarction, hardly any contraindication unless there is a myocardial rupture or VSDs. Every patient of acute MI is more or less eligible for primary PTC. Whereas in stroke, it's not like that. Every stroke, though he comes within the window period, it's not that he is eligible. So there is the role of a neurologist. Which patient we have to lay our hands, which patient, to what level, what modality we have to attempt. That's the purview of a neurologist. A good neurologist should be able to make, even prognosticate which patient is going to get up and walk. Now, this is one thing. Mind you, this is after intervention. Such a nasty sign, if you see this, because you are making the patient worse than what he is. The other complication, as I said, you have a successful recanalization, but you can produce severe cerebral edema. And mind you, we know that name I forgot, because the brain is in a cage. So if one side there is cerebral edema, it compresses the normal brain also. So the total brain is gone. So there is absolutely no chance for the patient to survive if you really miscalculate the decision. Now, we require some specialized hardwares for neurointerventions like DACs and road maps. And most important thing is soft guide sheets are required. In coronaries, what we have is a firm guides, which require sturdy ones which stand in the ostium. But when you go into the cerebral circulation, it's very tortuous vessels. So routine guide catheters will not go there and they will cause some dissections. So you require very soft guides, but yet they should be trackable. That's the reason why actually one of the major problems for brain strokes here is the cost. Prohibitively expensive, those hardwares. I'll come to that later. Now, this is NY catheter. I suppose most of you are familiar with this catheter. The tip is very soft. So this can be used. Unfortunately, 8 French doesn't come in there. All the treatment get is 6 French. I tried, but 8 French is not available. For booking catheter and sheath. And this is very important. Neuron max sheath. The sheath is so soft that you can go to the terminal part of the internal carotid artery. The reason why we require this type of things is we have to have a good support to pass on your subsequent catheters, otherwise they bump back because of the tortuous. Now, we require a specialized neurocath lab to decrease the complication rate. Routine cath labs also we can do, but if we have a dedicated neurocath labs, then to a great extent we can reduce the complications. Which have a large detector so that we can minimize the dye, have a roadmap, 3D pictures and 3D angios and dynasty, all these things they will reduce the complications. Now, this is the panel which it comes with the neurocath labs with the 3D imaging simultaneously. So with one injection, we will be able to know where is the location and extent and length and everything will be able to calculate so that our job becomes easy without doing multiple injections. This is a DSA roadmap. And you can see that you have a map over it and your guide wires and guide sheets you will be able to pass it. So that all these things we are minimizing the dye, which has a strong bearing on the complications. I don't want to go into the technical details. This is one thing when you perform neurointerventions, you occasionally face this problem. That's the bovine arch. It is like you see the horns noble. It creates difficulty in cannulating, especially the left common carotid. Now, some of the important considerations, anatomical considerations, the cerebral vessels have no external elastic lamina and a thin medial layer. This is very important because in coronaries we take appropriate size of the balloon to the vessel diameter and then you dilate to high pressures. In cerebral circulation, always, if at all you have to use balloons, you have to use lesser size diameter balloon and don't go beyond 2 to 4 atmospheres because they can cause perforation, dissection and rupture. And absolutely no concept of high pressure dilatation in cerebral circulation, unlike in coronaries, which by default you have to do in every case. We have to minimize the dye by diluting the contrast, use DSA and roadmap liberally, and most important thing, especially the beginners, if they want to do, always do a aortic arch injection so that you can see the osteoid vessels, neck vessels, so that you don't perforate or it cause dissection or embolization. And you always take a long runs because this is important because to see the collaterals and also to assess the tissue perfusion. These things will have a bearing on the outcome. So when there is no good tissue perfusion, then the results are not going to be good. And also, if you take long runs, rarely you will be able to see collaterals at the end phase. If a person is having good collaterals, we have to be less aggressive. Don't be very aggressive because God forbid something you do is dead. The collaterals at least are making him to survive or something like that. If there is no absolute collaterals, then those are the patients maybe you have to be more aggressive because you don't lose much. Now, these are the criteria that when you want to do any thrombectomy and mechanical interventions in the brain, it should be a large vessel stroke. You don't do for lacunar infarcts. Small vessels we don't do it. And infarct should be less than 1/3. That's what I'm saying, the selection of the case. Patient comes and half of the cerebral hemisphere is gone, but there is internal carotid artery occlusion or MC occlusion by your MRA. It doesn't mean that you go and do something about it. So if the infarct has to be less than 1/3. And there should not be any hemorrhage, even small hemorrhage. That's why when you take up the patient for interventions, plain CT is enough. You may not require, very detailed imageology for it. CT just to rule out, hemorrhage. And even however small it is, CT will be able to pick it up. The second one is the earliest signs of infarct, probably for an inexperienced person they miss. But a good person who has got an exposure to a number of neuro cases like neurologists, they will be able to make out the subtle signs of infarction. Sometimes the CT may look normal, But carefully look at it, the infarct is already formed. So those are the patients, I don't think you have to lay your hands on that. And of course, patient should be within the window period. Generally, for mechanical thrombectomy, the window period they say is 6 hours, but it can be extended up to even 24 hours if you have advanced imaging. Like there are certain things called diffusion, perfusion, mismatch. I'll come to that later. Now, like TIMI grade flows, we have TC grade flows. That is the same. 0 is no flow and 3 is a good flow. Now, routes are commonly we can choose either radial or femoral. Radial is not catching up. I'm not much experienced in radial route for cerebral interventions. But thanks to that angio-seed devices and because I have to put 8 French sheets, put an angio-seed, that's it. And then at least other complications are not there. Now, local previously used to do intravenous thrombolysis like NEMS, which is from 1995, but then evolved into intra-arterial thrombolysis. So you can give a lesser amount of thrombolytic agent. Recommended dose is around 20 milligrams of RTP or tenactibase, which is around 0.2 milligrams per kg body weight. The results are much better than intravenous thrombolysis because higher concentration of the agent there and higher recanalization rates which have been documented. But mind you, with intra-arterial thrombolysis also, the maximum is around 50 to 70%. Now, I'll show some cases where it is done intra-arterial thrombolysis. This is a 58-year-old male. Window period came at 5.5 hours, something like that. So he is ineligible for intravenous thrombolysis. Came with dense hemorrhage on the left side. And you can see MC on the right side, which is 100% good. Now, after intra-arterial thrombolysis, the microcatheter there is a good flow, and this patient has recovered in 6 weeks, reasonably well. It was not complete recovery, but he was able to do his own daily work. Now, by convention, anterior circulation is carotid system and posterior circulation is vertebral distal system. So this is a previous one is an anterior circulation stroke. This is a posterior circulation stroke. He's a 90% actually, 35-year-old hypertensive smoker. He came with a complete basilar occlusion. 2 vertebrals both join and form the basilar. And the basilar is completely knocked out. There is no flow on the distal basilar. He was unconscious, he was farting. I distinctly remember this patient, we lost hopes on that. He came very late actually, but still we thought we don't lose anything anyway because he's going to be, he's going to lose his life, so we went ahead. And we did intra-arterial thrombolysis for him in this laboratory, which showed 100% recanalization and dramatic recovery. This person has recovered completely within 2 weeks. So some of the cases are very rewarding, but mind you, it's not that what we see always is colorful. We faced a lot of problems also. Slowly we have evolved which patient we have to do. That's the reason I'm saying selection of the case is important because we'll be tempting to attempt those cases. Because you see today an MRI on the emergency, ECMC completely abandoned. So you think you want to go and go with it, but then there are a lot of other parameters which you have to consider before going to this. So selection is very, very important. Now some of the cases present as startling strokes. You must have seen some patients. Patient gets hemiplegia in front of your eyes, and after some time it becomes normal. Repeated episodes like that. This probably should make us suspect that there is an underlying critical lesion and small clot getting formed on it produces hemiplegia that spontaneously is lysed and then it becomes better. So always there is an underlying critical lesion if this scenario you face it. So he was an 80-year-old male. He came with the same presentation. Right in the hospital, he was recovering and he again became hemiplegic. So when we did an angio, that showed a very critical lesion in the supracranial ICI. So you can see the lesion, very, very tight lesion, very across. Then that time it is suitable for coronary stent, 4 into 18 millimeters mounted stent, and complete recanalization. And this person lived from 80 years to 90 years, and then at 90 years he died of myocardial infarction. But he didn't have any trouble, he was not bedridden, he was leading a normal life for 10 years. Now, this is the case of starting stroke which occurred at the origin of the internal carotid. You can see very tight internal carotid artery stenosis. And the thrombus sitting there. So what is happening is there is a tight stenosis, a small thrombus, circulation is knocked off, is becoming hemiplegic, and the story is repeating. Then this is after balloon dilatation. This is the self-expanding. Previous one is a balloon mounted stent. I was trying to show an example of self-expanding stent. And after this, as I told you, there is a residual lesion there. There are 2 points. One is residual lesion and external carotid is knocked off. Nothing will happen. Even the external carotid is totally knocked off, nothing happens. Even the bilateral external carotid is knocked off, nothing will happen except jam mastication, you get some pain. Otherwise, external carotid don't chase and try to open it up. You have to leave it. External carotid, even if it is knocked off, nothing will happen. Now, there is a residual stenosis here. That's what I was trying to make. Now, we can't be heroic in going and putting a balloon there and opening it up like in coronaries. Because post-stent, if you do dilate, especially the acute situation in carotids, it is catastrophic. So, what is the brain requires? It requires minimal flow action. And like myocardium, because when you do exercise, it requires more supply. Brain it requires very little bit of supply. Even if you produce trickle of flow to the damaging brain, that will prevent a massive hemiplegia. Yeah. This is a case, an interesting case. He's a 16-year-old male. He came with the left upper limb pain, very interesting case, and recurrent episodes of posterior circulation TA. He was having dysarthria and vertigo, recurrent episodes. He was treated by ENT specialists and all those people. Then we did angio, of course, carotid Doppler should complete knock-off of the circulation and that. So angio showed a rudimentary right vertebra on the other side, and this side circulation is gone. So is the vertebra. So we attempted PDCA to the femoral root, but it looked like a CTO, the didn't go. So blind puncture to the radial we went. Retrograde, and we opened up this. The reason why is those days I was using 8-inch guide catheters to pass bulky stents. So femoral, I have to go, I have to maintain access to the femoral. Then self-expanding stent. At that time I didn't have the peripheral stent in the shelf, so I put a valve stent for it. So there's a good flow in the subclavian, but if you see there is a vertebral osteotitation, which was fixed at the the coronary stent, and after that he never had any symptoms. So this was an example of recurrent post-operative circulation TAs. Would you have left him like this, maybe you would have landed up in a basilar stroke. Now, what are the modalities for the mechanical thrombectomy? We will come with some illustration. This is a MERCI device. It's a coiled wire which enters. This is a middle cerebral artery. There is a clot there. The MERCI device has gone there, and then put it into the catheter. Looks very attractive, very rosy, but it did not translate into clinical improvements in the trials. So this was a random. Now, what are the latest things which are available? Penumbra system. This is what we regularly use now. Clot extraction. This is nothing but a clot extraction. You take the catheter to the middle cerebral artery till the end, wherever is the clot. Then aspirate. The aspiration system is like any other aspiration system, but here the key is the catheter. I will show you subsequent pictures. The catheter has to traverse through all the curvatures of the internal carotid artery, go to the middle cerebral artery. So this is the importance in penumbra system. Yeah, so you require catheters which are very soft, then they should be trackable and maintaining the lumen, because when you are going through that and manipulation if it kinks, then you don't get the aspiration. So that's why these catheters are actually handmade and very expensive. Each catheter is 1.5 lakhs. And you may have to use 3 or 4 catheters in a given patient. That is the main drawback and crux for these things, modalities of treatment we want to use routinely for all stroke patients. Now this is the catheter, you can see how it can just coil and go. This is what I was pointing out. The internal carotid artery, this is the frame of internal carotid artery. You can see the arterioles before it gets bifurcated. I'll show this picture. Yeah, this is how it goes. What we call siphon of the internal carotid artery. The nostrum, especially the S-shaped bend, sometimes it's so, we struggle so much to negotiate this. Whatever, maybe 1 or 2% of cases we have to leave it because we are not able to track it. But thanks to this new hardware, some of the penumbra catheters, A68 and 4 max and 3 max, they go like, they slip into all those curvatures. Now, after this catheter is available, probably all these cases will be successful and go through those bends and curves. Now, the principle here is why it is expensive is each catheter is 1.5 lakhs and the other catheters are around 70,000 or something. It's a telescopic method which you have to use. If you see the blue one, that is neuron max sheet. And from there, we put a 5-French catheter, A68, and from there, you go with a 3 max. So catheter and catheter, and finally you reach the level. That's the whole assembly is, that's why it's expensive, because each catheter is expensive. So to go into that, isolated single catheter will not go there because it doesn't have a packet. Now, this is the patient there with a penumbra system, 50-year-old dense hemiplegia. Window period is 5 hours. You can see the titration there. We pass a wire over the catheter will go. Yeah, this is good recanalization, but if you see there is an underlying residual stenosis. We don't want to chase this because all that in the acute situation we require is, reduce all blood flow to the brain. And once the patient recovers, we can assess subsequently how much is the restenosis. If it's a recurrence of symptoms, then we can fix that up. In acute situation, to stent the middle septal artery is definitely a risky approach. Now, this is an interesting case. An internal carotid artery is 100% open with a tricular flow. With penumbra aspiration, you could get a very good flow. But if you see, there looks that the guy is getting extravasant. So we were really worried whether this patient has blood. That is why I am saying these neurocath labs, where there is an inbuilt CT there. So we can immediately do a CT and see hemorrhage is there or not. Because in cath lab, with injections, we won't be able to we won't be able to make out there's a hemorrhage. Unless there's a lot of gush which is going out of it. Otherwise, hemorrhages cannot be made out of routine cath labs. You require a CT. Previously, we used to ship the patient to the CT scan room and whereas these cath labs have inbuilt CTs are available. Of course, it's a crude CT, it's not a very fine CT there, but definitely we'll be able to make out whether there's a hemorrhage happening. That makes a lot of our job becomes easier and we will be more confident. Now, this is a patient where there's a left MCA 100% occlusion. With this penumbra system, it was completely opened up. That's why if you select the case and if you apply this correct technology, the results are good. The other advancement is the solid stent. Solid stent is nothing but a stent retriever. It enters the clot and pulls the clot back into the catheter. This is animation. The guide is this is middle septal artery clot and microcatheter. Through the microcatheter, this is the solid self-expanding stent which engulfs the clot and then get back into the system. And the whole assembly, the catheter, with the clot and the solid stent has to be pulled out. This is a illustration of a bacillus stroke. These are very resistant strokes actually. Not all the time that we are going to be successful. This patient is a 100% bacillar artery occlusion. Now, after the solid stent with the centrifuges, there is a good recanalization and a good recovery of the patient because the patient has come well within the window period. Sometimes you may have to combine the modalities, like stent, you have to deploy the stent and also aspiration. So this patient has got, if you see internal carotid artery, there is a fresh clot, probably underlying lesion. And from there the clot has migrated to the middle cerebral artery. So it has lesion in the internal carotid, which is thrombotic, and probably arterial artery embolization with the middle cerebral artery occlusion. Now we did a limited dilatation of the internal carotid, and then with the catheter, penumbra catheter. Here actually I can capture the picture. You can see the catheter tip in the middle cerebral. I zoomed in. You can see the catheter here on the right side and left side. There's a catheter, the bore is there, and we start aspirating it. And there's a good recanalization of the middle cerebral artery. We came down and fixed up this internal carotid with the stent. Yeah, these are the clots which have been pulled out with the penumbra artery system. Now, there are some more advancements have come that this time doesn't permit, so I have to give it there. Now, we know endovascular therapy with the stent retrievers like, solid stents or penumbra system or any mechanical thrombectomy has become a gold standard therapy if the person comes within the window period now. This is the last one indication now. Now, this is our published data on various multimodality treatments and strokes. And World Stroke Organization Award of Excellence was given to us for last 2021. Thank you. Now, the key to good outcomes in stroke, myocardial infarction is pretty simple. Simple means at least you need a technical skill. Here, definitely you need a lot of thinking, not by one but a team. Now, apart from intervention skills, the selection of the cases, what I've been repeatedly saying, because I got some phone calls from my colleagues that they have done and the patient did not recover. The reason is it's a selection of the case. For which, if you do 10 or 15 cases, anybody will be able to reach there and pull out the clots. But you really have to know which patient you have to pull out those clots. Because sometimes, if you recanalize a brain which is already infarcted, that is catastrophic. Now, successful recanalization could be there, but I told you as catastrophic this is one slide which I want to focus. What is called the diffusion-perfusion mismatch. If you see, diffusion is nothing but an area which is necrosed. The first frame. The second frame is perfusion. Perfusion means how much is the area which is getting less perfusion. Now if you see a mismatch is there, these are the ideal candidates to go for interventional therapy. That's why the so-called digital window period is no more actually accurate. See, some of the patients can come at 24 hours also, but there is a good diffusion-perfusion mismatch. They are still salvageable. The reason why we have to be aggressive in, again I want to emphasize is that sometimes it's completely, you can make a person normal, or at least he'll be able to do his own work. Otherwise, I don't know, you must have experienced in some families where one patient is there bedridden, they're gone, lifelong, with aspirations, bed sores. There is a help for them, they can't leave him, they can't get him to the hospital. We have some couple of patients like that, we have to do anything because there are burnt out cases. So that's the reason why if you act very early, at least some of the patients will be able to salvage. So it's always, it's a team approach that not only our skill when we go and do that, somebody has to guide us, each patient. Of course, in sometimes we may acquire the same experience which patient we can lay our hands on all, but it's better that a teamwork of neurologists, cardiologists, and a good radiologist can make a lot of difference. Stroke management cannot be simple like one cardiologist goes and does angioplasties. It's not that simple. Thank you very much.